Okay, sorry again. This is one of the academic, and my apology, there is a typing error here. So today we will be about shock and cardiac disease, and inshallah next week we will have a guest from Canada, my friend Dr. Yasser. So today I will be giving the basics, and tomorrow, then next week we'll have more details on, and we have cases discussion. So today kind of review and discussion, and we have a few questions that you guys, let's do poll. You'll see questions, and if you want to answer them, that will be great. Okay. So you can, if you can look at the question and answer them, and let's discuss them at the end. Okay, so I'm going to continue, but you guys can answer these questions. And once you finish, we will discuss it at the end of the session. So the objectives today is to talk about shock and also discuss some cardiac disease. Now, we will not go to the details of the cardiac disease because that will take a long time, but we will talk about more like a principle of treatment. So let's start with the first session. So it will take 45 minutes, and then we'll give you a break and then continue with the cardiac disease. So the objectives of this talk is to talk about definition, etiology, the diagnosis and investigation, what's the treatment options, and we'll give some scenarios and the management of there. I mean, we'll not discuss it in details, but we will discuss some of it because I would take the clinical scenarios can take a long time. Or if you guys like, we can do sessions only for scenarios. And then we'll talk about what you can take from this, and we'll give you some sites and articles to read, and we'll give you the references of this talk. So the shock defined simply is as an acute circulatory dysfunction. This is resulted from insufficient oxygen and nutrient delivery to the tissue that meet the tissue metabolic demand. And because of that, there will be cellular dysfunction. And because there is cellular dysfunction, there will be a side product. These side product, usually lactic acids and other things. And if it's left uncorrected, it leads to cell death for main reason, for deficiency of supplement and for presence of side product. So again, it's an acute circulatory dysfunction resulted from no oxygen and no nutrient or both to the tissue. This insufficiency is not must to be zero, but it can be anywhere from 0 to not meeting the metabolic demand. This insufficiency of oxygen and nutrient results in cellular dysfunction and start to accumulate metabolic product. These usually causes lactic acidosis. So the resulted in cell death if not corrected. The cell death is due to either insufficiency of the oxygen and supplement or presence of toxic side product. And as we know, the most common cause of death is probably due to shock and its consequences, even if the causes is not related to shock, because sometimes infection can lead to death, and the infection usually resulted from death. So it's a very common cause of mortality and death. And the prognosis of the main prognostic factors in shock is the duration. The second one is the severity. Is it mild, moderate, or severe? So the earlier the recognition of shock, the better the prognosis. And hence we start to use monitors, and we're using more and more monitors to try to pick up the signs and symptoms of shock as early as possible. Of course, we know that the shock can lead to, in addition to short-term morbidity, it can lead to long-term morbidity in survivals. And this, the most common is the neurological effect. And guess what? During resuscitations, we monitor everything. We monitor the heart, we monitor the oxygenation, we monitor the temperature, but we don't monitor, most of the time, we do not monitor the brain. but the most common or most important long-term severe neurological outcome is the neurological compromise. And this is in forms of first ischemia, and then when we correct, we cause reperfusion. So we cause ischemic injury, hypoxic injury, and also reperfusion injury. And therefore, recognition of shock very soon and initiation of treatment earlier can lead to complete recovery, especially if we can address the cause of the shock. So the main, or the purpose of it, early recognition, addressing the cause, and keeping the hemodynamic. When we say hemodynamic stability, we meant the enough oxygen arrive to the cell, enough nutrient arrive to the cell. The most important to remember points is the blood pressure, and especially the blood pressure in the preterm babies. Now, all of us, we don't use anymore the Korsakoff sounds. We use the oscillatory method to measure the blood pressure. And you have to know the oscillatory method depends on the pulse transit time. And I have to tell you that any measure in the pulse transit time below 30 is inaccurate. So having blood pressure low does not mean this is hypotension. So some of the, although there is normal values, and remember the normal values are not on a big sample size, on top of that, it can be wrong measurement. So first, do not depend on the blood pressure. Second, do not depend on one reading. Do not look at the blood pressure in a smart way. So look at the trend. Is it going up? Is it going down? And look to the relation between systole and diastole. Are they separated with wide pulse pressure, or they're getting together with small pulse, or they're keeping same? Are both of them going down, or only one of them is going down? These are very important to monitor the trend, because even if the measurement using the oscillatory method is not as accurate, because all the numbers are inaccurate, then the trend is accurate. So remember to monitor, to remember that the measurement we are using of blood pressure using oscillatory method. So we use the pulse transit time between 2 points. And remember that the pulse transit time is usually not accurate when it's below 30. So that's important to remember. Do not depend on blood pressure, because you can have a blood pressure low, but the oxygen and nutrient going to cell are maintained. So always remember to define the shock on the base that the oxygen going to the tissue and nutrient going to the tissue, not by the blood pressure. Now, the etiology are various, but in general, it's either because you have a pump, which is the heart, and we have peripheral blood vessels, and we have content. So either all are failing or one of them are failing. So one of the important factors in premature babies, neonates, especially premature, is loss of vascular tone, or what we call it distributive shock. Now remember, when the heart contracts, that contraction will propagate, and that's propagation, it will be moved, that contraction will move from the big arteries, from the heart to the big arteries, from big arteries to small arteries. With movement, it's getting smaller and smaller and smaller. So that contraction and propagation of contraction represent the systole. The response of the blood vessels to that propagation is the diastole. So if the tone is not okay, or the blood vessels, they will have a problem with the blood, with the delivery of nutrient and oxygen to the tissue. If you have a problem with the pumps, you will get the same. If both are okay, but the content is not there, then you are not okay. So the shock is either low vascular tone, what we call a distributive shock, or inadequate blood volume, or we call it hypovolemic shock, or decrease in cardiac function, we call it cardiogenic shock. Or the tone is okay, the volume is there, the heart is pumping, but there is blockage. That's what we call it obstructive shock. Or the content are okay, which is the blood. The heart is pumping, the tone is there, but the amount of the oxygen bound to the hemoglobin is not good. So that's what we call it dissociative shock. So you need to remember this principle when you treat and when you select the inotropes. Now the trend to give normal saline, then dopamine, then dobutamine is not anymore there. You need to assess, make sure what is the type of shock and treat accordingly. The distributive shock with or without myocardial function is the most common cause of hypotension and the most common cause of underlying shock. And that is true mostly in premature babies. So remember that when a baby is having heart contracting, this is the cause of shock. But remember that the tone is not okay. And there is an important point in newborn babies is the shunt. So the heart is contracting, the tone is okay, but the blood that is being shunted, the blood that's being pushed to the vein is going back to the other side through a shunt. And this shunt can be PDA, but also can be pulmonary. And the reason for pulmonary shunt is, remember that you have alveoli service. The alveolar service should match the pulmonary vasculature service. If you are underventilating a baby and the vascular service is not matching the pulmonary vasculature service, then that service that's not in contact with the vascular service will go to the other side without taking oxygen and leaving the CO2. And that's what we call it intrapulmonary shunt. So remember, the heart have a problem in your baby, cannot be as good as we like. There might be shunt and also called the vascular tone when you have a baby that behaving that he or she might have a shock. Now the distributive shock, as we said, we're losing the vascular tone. We're losing the contractions of the heart contraction. We are not keeping the propagation of the systolic contraction. The reason for losing the vascular tone are many. The most important is impaired the vasoregulation. Now remember that we have somatic vascular tone and we have cerebral vascular tone. And the purpose of somatic vascular tone is to keep the oxygen and nutrient to the brain fixed. And that's why when we do local oxygenation check in the brain, you can see that the brain oxygen is always fixed, while the somatic or other tissue oxygenation are variables. And the reason for variable going up and down is because the vasoregulation. Now, if this vasoregulation is lost from many reasons, if either defect or dysregulation of endothelial nitric oxide, this can be transient or it can be permanent. And that loss of endothelial nitric oxide causes impairment of vasoregulation. And the vasoregulation might not affect the vital organs, such as kidney or the heart or the lung or the bowel, but it would affect the brain. And remember, most of people, when we treat shock, we monitor everything, but not the brain oxygenation. And this is the most important things to monitor. Now, sometimes the vasoregulation is okay, but we have severe hypoxic ischemic injury. And remember, the hypoxic ischemic injury, the brain and the CNS are vital to maintain the neurovascular tone. And if that affect, it can cause loss of peripheral vascular tone. Release of metabolites, such as the pro-inflammatory factors, can cause also impairment of vascular tone and causing loss of the tone, or what we call it vasodilation. If we have allergy and release of some product due to the allergy, or what we call it anaphylactic shock, can also causes the loss of the vascular tone. So these the factors is the vasoregulation, the neurological input, release of metabolite from infection, and release of metabolite from allergy can cause loss of the tone. The other factors is loss of volume, such as bleeding before and during delivery from abruptio placentae or placenta previa, or bleeding from the baby to the mother, or twin transfusion, or we're losing the blood inside the important structures such as intracranial, or we sometimes bleeding outside, such as breaking or damaging the catheter, or bleeding around the catheter, such as the umbilicus. Massive pulmonary hemorrhage. And when we say massive pulmonary hemorrhage, sometimes we don't know, but when we say the term massive, we're talking about filling the whole lung. And I was not seeing the pulmonary hemorrhage as much as before, but now I've seen it more when I moved to a new unit, and most of common is associated with PDA. But I don't think the PDA alone can cause that, but usually associated with other factors, such as PDA and, for example, giving surfactant. And please remember that surfactant will not cause pulmonary hemorrhage. It's the way we give surfactant causes, is changing the pulmonary dynamics that causes it. The blood loss due to can be DIC, and because of the impairment of coagulation and then bleeding. Also, the plasma can leak to the extravascular and changing the oncotic pressures, or because of the change of the oncotic pressure status, or because of capillary leak syndrome associated with sepsis. Dehydration, either from inappropriate fluid giving or loss, and this loss can be insensible, such as from the lung during ventilation, if you're not using humidification proper, or because of diuretics. These loss of lung can cause hypovolemic shock. The cardiogenic shock is usually myocardial dysfunction. And remember that the neonate already have a poor myocardial function, not because the heart is abnormal, but it's just because it's a premature. Okay. Some of the common cardiogenic shock is heart is working okay, but as I said, the blood is going not to the other direction. So heart is pushing, going from left to right, right to the lung, back to the left, and so on. The heart is working hard, but the blood is in a vicious circle. So the PDA is very important. Asphyxia and improper oxygenation of the heart can cause depression of the heart and even ischemia and cause shock. So that's an important when you look at baby who having asphyxia and decision to cool and decision of what inotropes you should use. The infection of the myocardium, whether it's a viral or bacterial, can cause it. Sometimes the infection is congenital, such as enteroviruses, can cause myocarditis and failing. Arrhythmia, or different types of arrhythmia, although that's very rare and not as common. But again, sometimes it takes a long time, such as SVT, if lost more than 24, 48 hours, can cause shock. Arteriovenous malformation, behaving like PDA, can cause metabolic abnormalities. The heart need food, so hypoglycemia can cause them. Cardiomyopathy can cause, such as very common example is diabetic mother. An infant of diabetic mother can cause, whether it's a symmetrical or asymmetrical cardiomyopathy, can cause also shock. Obstructive shock, if you have restriction to inflow or the outflow, both can interfere with the cardiac output and function. So type example of venous obstruction is some cardiac anomaly, such as total anomalous pulmonary return, or core triatriatum, tricuspid atresia, mitral atresia, or acquired inflow obstruction, such as intravascular or air or thrombotic embolism, or increased intrathoracic ratio from pneumothorax, pneumomediastinum, even from ventilation. So remember always, if you have skills of echo, to measure the collapsibility of the inferior vena cava, because the most important differentiation between artery and vein on Doppler is the artery is regular, while the vein is everywhere. The waves are everywhere, and it should be collapsible. Loss of collapsibility are two factors. Either the volume is not enough, or the pressure from outside is high. So I usually see it, for example, what I call it CPAP inferior vena cava, because the CPAP and hyper CPAP can give a pattern on the wave of that. So it's important to remember that the venous obstruction can be acquired, and you need to remember that when you give CPAP or high frequency or even conventional ventilation. The obstructive also can be arterial, can be anomalies such as pulmonary stenosis or atresia, or aortic stenosis or atresia, or it can be vascular anomalies such as circulation or interrupted aortic arch, or it can be hypertrophic subaortic stenosis within the heart due to ventricular hypertrophy. An example of that is asymmetrical septal hypertrophy of the infant of diabetic mother. Now, how you diagnose it is very important to remember that the shock has signs, but also has a compensatory mechanism. So you need to pick up the signs of shock, but sometimes you can diagnose shocks by compensatory mechanism. Because there's always compensatory mechanism, an example of, for example, skin changing color, shifting of blood from the skin to other organs, muscle, okay, and also a response of the body to increase the contractility or increase the volume or increase the rate. All this can, so this compensation to the shock allow the blood pressure to be within normal. And even if the blood pressure is dropping, the perfusion to the vital organ is okay. And even if the perfusion is involved, the oxygenation is okay. So it's important to remember these factors. If the blood pressure is low, but the end organ perfusion is okay, it's okay. If the blood pressure is low and the perfusion to the organ is not okay, but the oxygenation is okay, then we are still incompensated. If you can pick that, that shock at that stage, probably you can help the baby. And remember, as we've said, that there is signs and there is compensation. So presence of compensation to the shock, it might lead to difficulty in diagnosis the shock itself. So something like cold extremity, pale skin, delayed capillary refill, tachycardia, weak, feeble peripheral pulses. And remember, some of these signs, even if you have low blood pressure, it might cause the diastolic pressure to be high. And it's vital to remember not to use the mean blood pressure. Mean blood pressure has no meaning. It's just a number to make your life easy. It's calculated from systole and diastole. It's vital to remember to use systole, diastole, the difference between them, what we call it the pulse pressure, and the trend. Are they going up or they're going down? Are they separated, going slowly separated, or they are going slowly met? Okay. Other signs such as ileus, And the ileus is caused because of decreased splanchnic circulation. Oliguria, because the kidney wants to conserve the volume. When the shocks start to be uncompensated, the most important part is start to have low blood pressure. But remember that low blood pressure is not enough because of many reasons. Because of difficulty in measurement, especially the size of the cuff. Second, because of difficulty in interpretations. Third, because of loss of normal values and trend, because of small sample size. And fourth, because the technique or the way or the mechanism we measure blood pressure is the oscillatory method. Okay, so when the blood pressure becomes low, don't panic and don't treat unless you assess the end organ perfusion, and perfusion is not enough. You need to assess the end organ oxygenation. And remember, there is autoregulation, and the point of autoregulation is to conserve the perfusion and oxygenation to the brain. And once that starts to happen, the brain functions start to change. The most important is loss of consciousness or change in level of consciousness and lethargy. And when the heart starts to be affected and perfusion of the heart affected, the heart function starts to be low and cause more hypotension, more shock, and you might need to cardiac stop to move. The other factors you need to remember when the perfusion and oxygenation are disturbed in preterm babies, remember that they have non-supported blood vessels. And because of this, hypoperfusion, reperfusion can precipitate and induce injury. And therefore, treatment of shock before or as early as before it becomes uncompensated or as early as possible, it have lots of advantage, including preventing hemorrhage and the subsequent periventricular leukomylation and the subsequent neurodevelopmental outcome as measured on 24 months of age. The other factors that you need to remember that there is a transient period where the vascular tone of premature babies are not as good as we want. And therefore, most of the time, when you have a cardiac shock or hypovolemic shock or obstructive shock, remember the tone in newborn babies are also, premature babies are not as good as we want. And that can accentuate the shock. The response to drop in systemic vascular resistance are altered in some situations, such as presence of medications, let's say like midazolam, or side product of the inflammation as resulted from shock. So usually when you have shock, the systemic vascular resistance should respond and should do autoregulation. That sometimes being interfered because these medications or inflammatory factors can cause vasodilation and also increase capillary permeability. In such cases, the systolic diaphragm pressure will drop. So if you have a normal systole and diastole is dropping, you need to think of the vascular tone. Okay? Normal systolic, in that situation, normal systolic pressure means nothing, but baby is in actual shock. So you need to remember to monitor the relation between systole and diastole. Do not use the mean. There is no normal values. Use the trend and assess the oxygenation and perfusion, not the blood pressure itself. But the dropping of both systole and diastole or dropping of one of them will help you to identify or have an idea what is the cause and probably help you to select the inotropes. How we investigate shock? We monitor the organs that has possible dysfunction. Okay, and by monitoring as early as possible, we can initiate the treatment. Do not wait for lab to start treatment of shock, because you will lose a vital time. Uncompensated shock mean there is inadequate oxygenation, inadequate nutrient. And when there is inadequate oxygenation, and the body starts to use the anaerobic metabolism, and therefore it will be anaerobic side product, which is the lactate and pyruvic. Lactate and pyruvate and other factors cause for you metabolic acidosis. Metabolic acidosis cause further dilatations and loss of vascular tone and affect the heart performance. And therefore, one of the important factors that you monitor is the serum lactate. And the serum lactate can be measured in the blood gas. And serum lactate, remember, there is serum, there is arterial, and also remember the lactate affect by the hyperonization of your sample. So please do not look to one reading, look to the trend. And there is something called lact time. Lact time is the time needed for lactate to accumulate and the time needed for lactate to resolve. And usually, if you look at the study, the lact time is usually 20% over 1 hour. So whatever the last reading, sometimes goes up to 50%, but most of the time is 20%. So when somebody say, for example, this baby was okay, and you find the lactate is 6, then there is some normal, because lactate 6, remember the lact time between the basic lactate and the current lactate. So the lact time is usually take 20% of the previous reading over 1 hour. So if you have the reading is previous reading 6, 20% of it is probably around 1. So within 1 hour, you will be 7. But if your lactate is 1 and you find the lactate is 1, then probably this baby was in actual shock over the last 6 hours. So from lact time, I can guess for how long this. And if anybody want to read about lact time, you can Google it. But also I have a nice topic on it I've written about what's the lact time and the importance of lact time in intervention of the shock. Other investigations is most of time is to find the reasons of the shock. These intervention might be vital sign check, such as heart rate, capillary fill, skin color, urine output, lactate, but also you need echocardiographic assessment. And always remember to monitor in a smart way. So remember to monitor the heart in a smart way. Remember to monitor the blood pressure and monitor. In addition, for example, the blood pressure systole, diastole trend, you can compress it over the last 12 hours and look at the trend. You can do a histogram. You can use a tachogram, or you can use a point care in the last 6 hours, and you can see the changes. Each one of these smart presentations of these vital signs can tell you something. And I hope one time we will do a session about smart monitoring. But remember, one reading means nothing. So also you need to use the cardio echo to assess the structure of the heart. You also need to check the constituents of your blood by CBC to look for presence or absence of infection. Look at the signs and electrolyte level to assess whether you're dehydrated or not. You might need to look at the cardiac anatomy and function. And you might need to repeat it, or you might need to use the tools other than echo to monitor the function. The flow in the superior vena cava is an excellent component to tell you how much your blood is coming, whether there is obstruction, and when there is a good volume. And it can tell you, is your shock volume replaceable or not volume replaceable? Now, the near-infrared spectroscopy is a way to measure the oxygenation. Now, we know that we can see the visible wavelength is from 200 to 600 nanometer. And the infrared or the wavelength become less than the visible is around 800 nanometer. Now there is between the visible, which is 600, and the 800, around 200 nanometers. That is not infrared, but is not visible. And remember, the 600 is the red light. So it's the wavelength is below the red light. That's why we call it infrared, but this is near the infrared. The wavelength of near infrared is very close to the hemoglobin, and it's very close to the oxyhemoglobin. So it measures the oxyhemoglobin. Remember that the pulse oximetry measure the about 600, and it measures the oxygen attached to the hemoglobin, and it's more to measure the arterial oxygen, while the NIRS measure more venous side of the oxygenation. So it measures around 75% venous and 25% arterial side of the oxygenation, while the pulse oximetry measure mainly the arterial. And therefore, the difference between them is the oxygen consumption. And that's what you want to see, oxygen consumption. And the measurement of NIRS depend on the perfusion, because you need a flow, and you need the oxygen attached to the hemoglobin to measure. So NIRS is vital to be used, especially during resuscitation, to monitor the brain, because you can monitor the brain and somatic. And remember, when you do resuscitation, is the most important is to protect the brain, because the other organs can be protected by the autoregulation, if of course is not failed yet.
Yahya.
Yes, sir.
Yahya. 5 minutes more to go before we break for questions. I know we are starting.
So I'm
late,
gonna I'm gonna pass. We can stop, and then when they start here, they start to use it in post-operative cardiac patients. And I have on July 14, I have a workshop online on NIRS. So remember to use the NIRS. The treatment of shock is addressing the etiology and treatment or improving the perfusion and the oxygenation to the vital organs, especially the brain. So we use fluid, inotropes, vasopressin, hydrocortisone, and we use. Can you please mute yourself? Please mute yourself. Please mute yourself. Thank you. So the fluid therapy, it's always better to give 10 to 20 ml per kg than increasing the volume. And it's always good to use crystalloid when you give. So if you have a shock and you're sure that your shock is volume replaceable. How I know? I do Doppler for inferior vena cava, or I do Doppler of aorta. And if there is variability, more than 30%, then mostly your shock is volume replaceable. Same can be applied for inferior vena cava. So to know if it's volume replaceable or not, you need the Doppler of the aorta. And there are very nice studies on that to confirm. You need also to give if there is anemia, and you need to replace with the blood. And when you replace with blood, you remember to use packed RBCs, or if you use whole blood, you need to think whether you're using Lasix or not. Albumin can be a replacement, but it's not, because it's a blood product and is not superior to the normal saline. However, sometimes you can use it for certain situation where if the oncotic pressure is low. Again, you need a sufficient volume. You can measure the central venous pressure, rarely being used, but sometimes can be used. The normal in many of them, the central pressure should be maintained somewhere between 5 to 8 millimeter mercury, but again, most of the time we do not measure it. You need, if you measure the central venous pressure, you need to make sure that you don't have structural heart disease and the ventilation does not affect the situation. Now the inotropes to improve the cardiac function. Now I will have a session on inotropes only, but there are many types of inotropes that we can use. The first is dopamine. So this is a dose dependent, and the dose is somewhere between, if it's low dose, between 5 to 2 mic per kg per minute, it's stimulate the peripheral dopamine receptor. It increase the renal, mesenteric, and coronary blood flow because it causes a little bit vasodilation. When you increase the dose, it becomes more inotropic and chronotropic effect, and increase cardiac and mortality, contractility, and the rate. Because it's more like norepinephrine. It depends on norepinephrine store. The dobutamine, however, can be used on a, now remember, never use more than 10 mic of dopamine without hemodynamic assessment, okay? Because you will not get benefit, but you will get more side effect. Because on low dose, you get your dopamine effect, and on higher dose, you get your inotropic effect. More than that, you won't get any benefit, but you get the side effect. Dobutamine is like a synthetic catecholamine, and it has more cardioselective inotropic effect. So it's used only when you have cardiac is a problem. When we have a cardiac, you remember that both systole and diastole will go down. Well, when you have only tone, you remember that only the diastole will go down. And remember, if there is a shunt, then probably both of them will not be affected because you need to treat that shunt. Epinephrine can affect.
We will.
Epinephrine can. Okay, epinephrine can affect both the inotrope and the heart and the periphery. So that's why it's being used in the shock, or in the used in shock and in anaphylactic shock or in allergic shock, because that affect both the heart and the peripheral circulation. But remember, Rula, we already lost time from the beginning. So yeah.
Okay.
So epinephrine is not as common, should be used, but it's mostly used in resuscitation. Milrinone is also a phosphodiesterase type 3 inhibitors, and it's have inotropic effect, but has so it improves the contractility, but also have pulmonary blood pressure relaxation effect. So remember when to use, when you need a pulmonary vascular resistance is high, you can use milrinone. You can use vasopressors such as dopamine in a higher dose, 10 to 20, because in low dose you need to, it's a vasodilator. In intermediate dose is a cardiac, but in higher dose it becomes vasopressors. And if you need dopamine, the vasopressin is probably so. So if you need dopamine more than 10, the vasopressin is probably safer if your sodium is okay. So remember to use vasopressin. And sometimes if it's only peripheral and the heart is okay and you're giving dopamine 10 and you need a vasopressor effect, then norepinephrine for peripheral is better. And if the heart, then epinephrine is better. So it's vital to remember when you use dopamine, not to use the side effect of it. Okay. Hydrocortisone, when I use it, it's in unresponsive seizure. Unresponsive shock, resistant shock. Because hydrocortisone works on many ways to improve your blood pressure stability. It has effect on the heart. It can help or potentiate the effect of other sympathomimetic agents. It can calm down the side product of many metabolic derangement. So it works in many ways when you need to consider. And I usually, when I consider the steroid, I do some baseline steroid cortisol level. Even if the level is normal, remember when the patient is in shock, you need to have a higher dose. You need a stress dose or a stress level. So even if your steroid level is normal, you might need to consider steroid. So I'm going to stop because I've started some scenarios. I'm going to stop here and ask for questions, and then we will continue the other sessions if there is questions.
Floor is
From
open
our,
for questions, dear
if
doctors.
our fellows want to ask.
So far, I have received no questions.
So you want to go for a prayer for 10 minutes and come back?
I guess, yeah, it's the time. It's good for prayer break and come back 10 minutes.
Yeah,
It's 12:25.
Yeah, let's come back at 12:30. Is that okay?
I think yes, it should be fine.
Okay.
12:30 we'll start the second session. Thank you.
Okay.
MQH 23. Fine. Dr. Yahya. We have one question from one doctor. before we start our second session. لا شكرا دكتور يحيى مش على
للأسف ما بيسمعونا.
Dr. Yahya, shall we start now? Our second session? Dr. Yahya, I think you have muted yourself.
So, any questions?
Yes, there was a question. Dr. Rubina asked, what is the dose of hydrocortisone used?
Oh, well, first you can check it. I don't like to describe doses in my presentations, but you can use somewhere between 0.5 to 2 milligram per kg. But I always prefer to check it depending on the gestation and postnatal age and the situation and the cortisol level before I decide. So I do not recommend that anybody, even if you know the dose by heart, to give a dose without pre-checking it. And it's actually medical legal if you give a dose without checking it. You don't need to remember the doses, but you can always check it. But it's somewhere between 0.5 to 2 milligram per kg. But I don't recommend that you take this, and I don't write it in my presentations. I think you have to check it. Yeah.
Okay,
Any more questions?
Anna? Yes.
Yeah.
If we suspect that the baby is having this problem because he's having viral infection, hydrocortisone is contraindicated or still can be given?
No, can be given. Hydrocortisone, yeah, your viral infection, either no treatment or you decide treatment. Viral hydrocortisone is masking the symptom. It's not interfering with defense or the fight between the body and the virus. It masks the symptom, the site, but it does not interfere. It's actually, it's a good, because when you have stress, your steroid go up. So it does not affect, for example, you can give a steroid, for example, for corona patients. It's not wrong to give it, although there is a study that methylprednisolone can be used, but again, because the virus, either you have treatment or you have no treatment. So the decision is not based on whether you're giving steroid or not. It's whether there is a treatment for the virus or not. Yeah.
Okay, thank you very much. I think we can start our second session, Doctor.
So let's talk about some scenarios. We have low birth weight infant, and he or she just delivered. So what are the causes of shock or hypotension in that situation? Is poor vasomotor tone, immature myocardium, and the most of the time, these babies are very sensitive to the afterload and giving boluses. And there is always dysregulation of nitric oxide production, which is the main cause of loss of vasomotor tone. Now, again, what is hypotension in newborn is unclear. Remember, there is no numbers. Arula, there is somebody asking you, asking questions. Oh, yeah, that's you. Okay. So what is normal blood pressure in newborn is unclear. Remember, we use the oscillatory method, and it's used the pulse transit time. And what is, when the blood pressure below 30 is not accurate, and therefore don't depend on the pressure. One reading, two readings. Look at the trend. Look at the trend as a graph. Look at the trend as a histogram. See the difference between dystole and diastole, whether they are meeting or they're separating, whether one of them is low or both of them are low. The mean blood pressure is inaccurate. The use of mean blood pressure in relation with gestational age is totally wrong, and you should not use it. It's vital to know that mean blood pressure is a calculation number from systole and diastole. When we use a pressor therapy in a premature baby, we are worsening the outcome. The outcome when with using pressor is usually poor, but we don't know whether this related to use of inotropes or pressor agent or because of the severity of the hypotension. Remember to use dopamine in low doses, not more than 10. Remember not to use inotropes or pressor therapy without priming the circulation by normal saline. Remember not to give very large boluses. Remember to give small boluses and give it over a little bit longer period of time if the baby is not on immediate danger. Giving large boluses, giving fast boluses can cause and contribute to bronchopulmonary dysplasia and also contribute to the IVH. Always consider the steroid if there is no response to dopamine. If you need dopamine more than 20, consider hemodynamic assessment and consider other pressor agents. Remember that there is autoregulation that will cause pallor, mottled appearance, and poor perfusion and myocardial dysfunction to compensate for a drop in the systemic vascular resistance. Remember that these babies might be eovolemic. So big volume replacement is unnecessary. Remember, these babies might have pulmonary hypertension when you consider inotropes. So the recommendation of dopamine with or without dobutamine should be up to 10. Do not use more than 10 unless you do assessment and see what is your missing. The trend of using dopamine and dobutamine at the same time is not acceptable unless you really need it. Milrinone is always should be considered as afterload reduction with inotrope defect because it improved myocardial function and it dropped the pulmonary blood pressure. Sometimes, I'm not saying that we should not use dopamine more than 10. However, you need hemodynamic assessment And you need to ask yourself, if I need the vasopressor effect of dopamine more than 10, why don't consider vasopressin or norepinephrine? The clinical assessment should guide your therapy. And remember the lactate building or the lac time. And remember that the lactate, there is arterial, venous, and sometimes it affected by the heparin. So these are very important when you assess the lactate and when you give. The septic shock, so we have that's a premature baby consideration. The septic shock can cause hypovolemia, can cause myocardial function, can cause peripheral vasodilatation, and can cause pulmonary hypertension due to acidosis and hypoxia. So remember, these can be all together and can be separated. So when you have a septic shock, think, is it systole mainly? Is it diastole? Is the heart functioning? Is it a tone? Is there peripheral vasodilatation? Is there hypertension with it? Is there metabolic acidosis or hypoxia? There is no point of keep going and giving medication and you have acidosis. You have to correct the acidosis. And there is no point that your tissue hypoxia and you keep giving a replacement. So remember that. Remember when you give the normal saline boluses and resuscitation is totally different when you treat compensated shock. So in resuscitation, you can give higher doses and you can boluses when you resuscitate. And you can repeat it as much as you need, up to 3 times. But when you do septic shock treatment, not resuscitation, now consider the hypovolemia, myocardial dysfunction, and peripheral vasodilation and pulmonary pressure before you decide. Cardiac echo is very vital when you treat the septic shock. Can give you the cardiac function and superior vena cava flow and the cardiac output, and if there is shunting. It's vital to know that your shock is replaceable or not replaceable. Because sometimes if it's not replaceable and the vena cava is not collapsible, then probably you're giving worse by giving more inotropes. You're giving flooding the lung, you'll get more B lines, you'll get less A lines. And now extracorporeal membrane oxygenation is not advisable, and you can see compare the result of centers using it versus the center not using it have the same mortality and morbidity rate. So I do not advise it. You need to treat the duct when possible if you have a shock, especially if it's along by shunt from left to right. Amani, please mute yourself. When you need to use dopamine more than 10, consider hemodynamic assessment and ask yourself, the vasopressor effect of dopamine more than 10, should I replace it with norepinephrine or vasopressor? Dobutamine is used to enhance cardiac effect. So if your systole is okay, then you don't need to consider it. Always remember to give prime when you start dobutamine if your hypotension is volume replaceable. Always give time when you do changes, 30 minutes to 2 hours. When you have cardiac function compromise, look at your afterload and preload and consider your intrathoracic pressure if you are ventilating, whether invasive or non-invasive. Always treat high CO2 and metabolic acidosis before you give more oxygen in patient with shock. If your neonate having low vascular tone and its resistance to pressors or vasopressors, they need probably adding more vasopressor agents. When this happens, mostly they are steroid deficient, or their adrenal is not responding to the crisis. And because of that, because of the steroid, the receptors of the pressors will be downregulated, and in giving more dopamine will not help. So you need to consider steroid. Again, if you need dopamine more than 10, please assess. Always consider low-dose steroid. Okay, when you do steroid, please ask for basic cortisol level. You don't need to wait the level, but you need to do it so you understand whether it's deficient, insufficient, or you are not responding to the stress. I'm going to pause this. So take home message from this. The shock in newborn babies, either low vascular tone or loss of volume or loss of cardiac function or restriction to the blood flow or inadequate oxygenation dissociated curve. Always do not look to the numbers. Always look to the trend. Try to treat as early as possible. Do not use routine, normal saline, then dopamine, then dopamine. Always assess. Do not look to the mean. Look to the systole and diastole and the relation. Look to the capillary refill, skin color, urine output, lactate level. When you have a lactate, please remember your lac time, or the time for accumulation or clearance of the lactate. Always ask for help. Never give dose without checking it in the system or in a reference. The treatment should be keeping the nutrition and the oxygenation to the end organ and finding with the treatment of the underlying etiology. Fluid, inotropes, vasopressor, and hydrocortisone is used to treat. When you give a fluid, you should assess the baby if the shock is volume replaceable. When you give fluid, give a small dose, 10 milligram per kg. Give it a little bit longer time. Consider whether using inotropes or vasopressors. When you're using both, like dopamine that can cause vasopressor, think if I need over the inotropes, whether the receptors of dopamine is not working and it's downregulated and it needs steroid, or I can use other vasopressor other than dopamine, because the high dose will give you of dopamine will give you more side effect. So I don't use another agent with vasopressor with low dose. Now, if you want to read, there is a clinical practice parameters of hemodynamic of newborn babies. It's a very nice article, if you can read it. And there is another one done by Patrick, but here is a list of most of them. And they're very nice, especially this one, diagnosis and treatment of neonatal hypotension outside transitional period. And this one is also a nice article. And I think I am done. And if I have any more questions, if no question, I can go to the next session. But if I can, I will be happy to take questions, if any.
So far, I did not get any. Let us wait.
Any questions?
Yes, Dr. Hayam is asking, I would like to hear more about lag time.
Okay. Lag time is the time for accumulation and clearance of the lactate. And lag time usually it's 20% of previous reading over next 1 hour. So let's say that the lactate is 6. So 20% of 6 is around 1. That means the lactate was 5 in the previous 1 hour. 20% of 5, around 0.8. So in last 2 hours, before 2 hours, the lactate was probably 4.8, 3.8, and so on. So when you have a lactate of 12, remember the lag time. And don't say the baby was 1 hour ago was stable. Probably this baby start to have been shocked a long time to accumulate the lactate due to lag time. When the baby start to respond, you will start to clear the lactate because you start to not to use deoxygenated metabolism. So it needs time. So you don't need to force the baby to respond. Once the lactate is going down, then just wait. Your treatment is okay. Do not add more treatment. Now, of course, not only the lactate, you need to use other factors. But remember the lag time, which is the rate of accumulation of the lactate and the rate of clearance of the lactate once the baby starts to improve. Did I answer the question? Yeah.
Yes, thank you. Yes.
Okay.
And Dr. Randa Bishtawi telling you, yes, it is clear. Yeah, it was clear.
Our fellows, no questions? No questions? They're good?
Our fellows. طيب.
No more questions?
I think there is a question popped up here. Dr. Hiba is asking how reliable is the lag time when running capillary samples due to squeezing?
Well, I am assuming when we talk on lag time that you are collecting it in a certain way. So if you're collecting it by capillary and you're always squeezing, should be reliable. Even if it's wrong when reading, the trend will not be wrong. But if it's only one reading, an outlier, and the rest are not squeezed, then you need to reconsider. So, and also consider that capillary lactate is different from arterial lactate. And if you're using heparinized sample versus non-heparinized sample, also affect the lactate. So depend if always the same sampling way should be okay. But if only one or two and the rest are not, the sampling technique is different or changed, then probably you need to keep that in mind. But remember that when it's negative, it becomes positive. So when you have always wrong technique, then the trend is acceptable to be looked at. Any more questions?
So far, nothing. Can we please proceed to the next session?
Yeah, so next week, inshallah, on July 14, there will be session on NIRS, and on July 15, there will be sessions on hemodynamics and scenarios. So remember that. This is just an introduction today to the next session. There will be more details. So we have July 14 and July 15, not July 8, July 15, remember, 14 and 15. So let's talk about cardiac diseases. Aliyah. Dr. Aliyah.
شكلنا عملت له ميوت.
Let me mute yourself. Okay, so in this we'll talk about introduction, the incidence and survival, clinical presentation, and evaluation. We'll talk about a little bit of lesion-specific care. We might mention the acquired, if there is pharmacology, and we'll talk about arrhythmia. We will leave some of the topics because it's too long and we need time, but we will try to pass over it as much as we can. Now, you need to know that pediatric cardiology is very young field, and neonatology even, neonatal cardiology even younger. So remember, when there is evidence or care, remember that it's very young field. So I'm going to pause this. Now, the outcome of a cardiac disease depends how early and accurate we identify. And in addition, we need to evaluate and identify the secondary effect of the cardiac disease on other organs. And the most important assessment of cardiac disease is the first assessment, whether it's by a neonatologist or by a pediatrician. Our responsibility is to assess, find the pathology, and find the effect of the pathology on other organs. And therefore, cardiac care is a multidisciplinary team. You need lots of people. You need cardiologists, neonatologists, intensivists, surgeon, radiologists, and so on, nurses, occupational therapists, and so on, many people. The side effect of cardiac diseases on the other organs, such as failure to thrive, increased risk of infection due to wetting area, pulmonary vascular, secondary pulmonary vascular disease, development, neurological problem, all can be a consequence of cardiac disease. Now, the incidence is very low, it's somewhere between 0.6 to 0.8%. And it seems that the incidence has not changed over last period of time. Sometimes, so the incidence is somewhere between 0.6 to 0.8, but sometimes you find some literature, the incidence is higher. They're probably considering or including minor asymptomatic cardiac lesions, such as bicuspid aortic valve, or other minor lesions that sometimes, even if we don't discover it and we discover it by chance later on life, it won't affect the quality of life. So here is more about the percentages about different cardiac lesions. Okay, and I'm not gonna go pass through all of it, but you can see that the incidence varies, and it depends when the baby was assessed. So for example, at birth, the most common that we've discovered is transposition and hypoplastic heart, while in the second week, the most common we discover is coarctation of aorta, and later on, after 2 weeks, the most common are the VSD. So you need to remember that some of the diseases that you might not discover at birth doesn't mean that the baby, even if you have done structural assessment, doesn't mean that there is no congenital heart disease. The presentation varies. It depends on 3 elements: the type and the severity of the lesion, the alteration in cardiovascular etiology, and in utero effect of the lesion. Type and severity, change in cardiovascular physiology. Yeah, please mute yourself. Please, can you mute yourself? Tell, please mute yourself.
Okay, so ORecognizing is a mainstay of their.
Tell, can you mute yourself? Can you mute him? Can you mute him? I'll take him out. Can you remove him? Remove him. Okay. So the timing of the presentation, depending also on these 3 factors. So the timing of presentation and the presentation itself depending on the type and severity, the change in the physiology, and the in utero effect. Overall, the cardiac emergency are not so common. Most of the serious cardiac disease present in the first few days of life. Some of them, these lesions are life-threatening. For example, if you have a complete isolation between the right and left side. The primary diagnosis of DTGA is one of the example on parallel non-mixing circulation. I want to ask a question. What is DTGA means? Like how you, if I do not understand it, how you can tell me or how you can help me understand what D stand for? What D stand for? Anybody want to answer? Anybody want to answer? What is D stand for? No, mute yourself and answer, don't text. Okay, dextro, and then what?
Dr. Hiba answered dextro. Dr. Hiba answered.
Okay,
Dextro.
we know D, dextro, and L, levo. Okay, teach me, like
Describe.
what is that?
Describe.
What is DTGA? If I always mix up between LTGA and DTGA, how you help me to always remember?
Yes, Dr. Yahya, this is Ahmed speaking.
Yeah, go ahead, Ahmed.
So D for de-looping. So the normal development of the embryology is there will be looping between the major arteries. So if there is de-looping, means that they stayed in the same place. So so this is a true TGA. So the aorta coming from the right ventricle and the pulmonary coming from the left ventricle. So de-looping. The normal, it's to happen in the embryology is to have looping.
Mm-hmm. So
This
let
is
me.
how I remember.
Yeah, let me make it more simple. You're right, you're correct. But let me remember D represent the right ventricle. That's what Ahmed meant. So when we say D, mean right ventricle on the right. So it is normal de-looping. So the right on the right and the left on the left. So remember, D represent the right ventricle. So when D mean the right ventricle on the right, it's dextro. When we say L, the right ventricle is on the left. So DTGA mean there is a TGA and the right ventricle on the right and the left ventricle on the left. So it's no de-looping. While when you say LTGA mean the right ventricle went to the left, and because it's abnormal de-looping. So remember, DTGA is a true TGA because the right ventricle on the right and the pulmonary is taken from the left. And so again, the pulmonary is arising from the left ventricle and the aorta arising from the right ventricle. And therefore, because there is no connections between the right and left, because the left side take blood from the lung and then pushes the blood, supposed to push it to the systemic, it pushes it back to the lung. So take it from lung, push it back to lung. The left side supposed to take it from, the right side is supposed to take it from inferior and superior vena cava and then push it to the, through pulmonary to the lung, but it pushes it to the systemic. So the blood coming from systemic going to systemic, the blood coming from the lung going back to the lung. So there is complete isolation. That's what they call it parallel. So we need a mixing, and the mixing depends on the PFO, PDA, or Rush-King procedure if we do. So the most important in this situation is not compatible with life unless you do an emergency shunting between both sides, if there is no shunting. And if there is shunting, you need to keep it open. So if there is a PDA, you need to keep the PDA open. So this is incompatible with life if no intervention. Again, if the PDA is already open or the PDA is small, then you need to start prostaglandin or prostin. Now, in my practice, I have no evidence. When the duct is closed, I go with higher dose, like a loading, and then I go down, I down-regulate the dose. When the duct is already open and I want to maintain it open, I start with low dose and go up to keep it open to a certain level that I want. Now, if there is no PDA or the PDA is closed, there is no point of using prostaglandin. You need a surgical shunt to be created to save the life. Until, of course, you do the correct staging, correct procedure, which is the switch procedure. The other lesion is critical obstruction. When we say critical obstruction, we mean there is no gradient. And when there is a critical obstruction, if it's on the left side, then the left side depends on the right side through the PDA. When critical obstruction of the right side, then the right side depends on the left side for the PDA. So it depends where is the obstruction, the shunt should be left to right or right left to depend on that. And that situation, you need to keep the duct open. So you need to give prostin. And you can see if you have no clue, it's not wrong to start prostin until you make sure that you can see the heart. So if you don't have a clue, you can start prostin. And once you have the clue, you can stop prostin if it's not useful. Example of critical obstructive left heart lesion is hypoplastic left heart. We know this can present as a shock. This can be present as fetal screening, and also can be present if you have screening because of failed cardiac disease screening postnatally, or sometimes if you've done the echo for something else. Or it can present with hypotension or even shock. So in that situation, you can see the left side are completely hypoplastic with various degree. It might include aortic stenosis, and it might include also coarctation of aorta or interrupted aortic arch. There are various types of hypoplastic left heart. The critical obstruction can include also critical aortic valve stenosis. When we say critical, mean there is no flow or very minimal flow. Coarctation of aorta, it depends where, is it pre or post, but most of them are critical stenosis and they need interference, whether surgical. If it's post-ductal, then mostly duct will not help. If it's a pre-ductal, mostly the duct will not, but if it's post-ductal, then you probably. So it depends where is the obstruction, but again, giving prostin and giving the duct open, it will help, but it will not have. We know that there might be side effect of prostin, such as hypotension or allergy, or signs of shock and hypotension. But again, the degree of benefit is way higher than the degree of harm. So if you have a suspicion, start prostin until you sort out the lesion. Interrupted aortic arch have same problem. You need on PDA. The right side obstruction, the left side, the right side will depend on the left side through the PDA. So you have left to right shunt. And the baby, of course, if it's completely obstructed and there is no shunting, and remember, shunting through PFO or ASD will not help because you have obstruction at the pulmonary valve level. So when we say critical, it's mean like more than 80% of the gradient are preventing from passing through the valve. Example, pulmonary atresia, complete absence. And again, it depends on the length of atresia. Shunting through PDA might help, and you need to keep the duct open. There are many variants of this. It can be associated with right ventricle or right side hypoplasia or small right ventricles, and various lengths involving of the artery, involving of the valve. There are various types of pulmonary atresia. Sometimes pulmonary atresia associated with aortopulmonary collaterals that help the shunting, sometimes not associated. You sometimes have a critical pulmonary valve stenosis, not atresia, but the degree of stenosis, more than 80% will interfere with the gradient. The other type of sin is total anomalous pulmonary venous return, and you can see that is very difficult to diagnose before the appearance of teacher. You used to diagnose it earlier with figure 8 or snowman appearance, but that will be too late. Most of the time we discover. So again, if you see signs of pulmonary hypertension, and increase right side, then look at the pulmonary vein. If you have pulmonary hypertension, you need to figure out the pulmonary vein, at least 3 going to the left atrium. And if you don't see 3, then think of total anomalous pulmonary venous return. Now, that can be obstructive. So if it's infracardiac, or the most common obstruction, but most of the cardiac, which means the total anomalous is still coming to the heart. But sometimes it's extra supracardiac, where the usually total anomalous, they make one artery or one vessel, and this vessel goes to the superior vena cava, or it goes to the inferior vena cava, or it goes to the heart. Most of the time when we look total anomalous, we look to that confluent. That is not always the case. Sometimes these branches may do the wrong connections by one by one. But most of the time, 90% is they make one vessel called the confluent, and the confluent goes either to superior vena cava and supracardiac, to the cardiac, or to the infracardiac. Because it's across the heart press on it, it causes obstruction. And sometimes in the cardiac, less severe obstruction can happen with the supracardiac. Now, the treatment depends whether there is obstruction or non-obstruction. And they need, final, there will be recorrection. But most of the time, the treatment depends whether there is obstruction or no obstruction. Sometimes they don't intervention because, there is requirement for the success of surgery, including the size of the baby. So if it's not obstruction, the treatment might be postponed until the baby got a good size. Without correction, of course, they got significant morbidity and cardiomegaly and cardiac changes, such as what we said on the X-ray will appear a figure 8 or snowman appearance. But with improvement of the screening and presence of availability of the echo and training more people, now this is rarely happen. Now, of course, the earlier the recognition, the better. Key finding, you get cyanosis, and sometimes if the baby admitted, you get desaturation before the cyanosis. You can get congestive heart failure. You can get collapse and shock, and you can hear murmur, and you can cause arrhythmia. The other critical is Eberstein anomaly, or the atrialization of the ventricle, where the cuspus is so big on the right ventricle, on the tricuspid, is so big that it becomes redundant and drop to the ventricles. So do not stay on the level between the atria and ventricle, it drop down. And because drop down, it gives the space to the atria and take it from the ventricle. And usually the presentation is a little bit early with cyanosis, and then sometimes it can cause outflow obstruction. It depends on the severity, and then sometimes mild, sometimes big size. It depends on the date of the operation. So I'm done with the first session of cardiac disease. If you have questions, I can answer.
Yes, we have like 2 more minutes before we move.
Yeah.
Any question?
Any more questions? No? Should we move?
I'm not getting any on the plat. Okay, I think we can move, Doctor.
Yeah.
Please, thank you.
So what is the clinical manifestation of cardiac disease? First, cyanosis. Cyanosis is discoloration of skin and sclera and mucous membrane. And cyanosis will happen if the hemoglobin is not attached to the oxygen, it's attached to carboxyhemoglobin. So the CO2 instead of oxygen to the hemoglobin. And the color will not change until about 5 grams. So if we assume that the hemoglobin at birth is 20, then the baby need to have 5 grams to be carboxy and 15 grams to be hydroxyhemoglobin. So which means the saturation will be 75. So if you measure the saturation by pulse oximetry, will be 75. So you get 75 down to 75 to see the cyanosis. However, that's different if the hemoglobin is 15, because 5 grams is only 33% out of, and 10 grams will be hydroxyhemoglobin, not carboxy. So 5 out of 15, that's about 33%, which means goes down to 76% saturation before you see cyanosis, and so on. If the hemoglobin is 12, then 5 is probably 40%. So the saturation will be 60 to see the cyanosis. So you remember the saturation check is way before cyanosis. So if your baby, you wait until saturation happen or cyanosis happen, then you're a little bit late. Cyanosis can be seen in babies who's not in the ICU. Okay, so here they mention 3 grams, but most of them they mention 5. But you can use also the term 3 grams. But I use the number 5 grams. Okay. So again, the saturation should be way down before. Remember, when you have polycythemia, you because of the saturation might take longer time to see, and so if the hemoglobin is 22 and we say that the carboxyhemoglobin is 5, then 17 is remaining. So the desaturation will occur, or the desaturation will be around 80 to see the cyanosis. So the higher the hemoglobin, the shorter the desaturation before the cyanosis. So you need to remember that when you look at your cyanosis. Okay. So you need, of course, to check between innocent color change on cyanosis, including the acrocyanosis. Sometimes there is difficulty depending on the light and the color of the skin. Muhammad, can you mute yourself, please? Thank you. So again, there is other innocent problem that you need to check. So when you check the cyanosis, depend on the light around you and also depend on the color of the skin. Okay. And therefore, other means, if you're suspicious, you need to other means such as pulse oximetry or NIRS to make sure that your baby is okay. Okay. So the differential diagnosis, cyanosis can be any: cardiac, respiratory, CNS, metabolic, many reasons that can cause cyanosis. Pulmonary example, primary pulmonary disease such as pneumonia, RDS, arteriovenous malformation, obstruction, pneumothorax, extrinsic compression, can be central nervous system, cause hypoxia and respiratory depression. These are an example of differential diagnosis of cyanosis, so I'm not going to go all over it, but you can see it's a primary cardiac lesion, can be pulmonary lesion, and there are many cyanotic, and there are mixing cyanotic or non-mixing cyanotic, decreased pulmonary blood flow cyanotic disease, increased pulmonary flow cyanotic cardiac diseases, and again there is pulmonary diseases. Other diseases can cause central diseases. Pulmonary hypertension can cause cyanosis, and so on. Cyanosis can be due to abnormal hemoglobin, because remember, polycythemia can increase the level at which that you will see cyanosis, and also methemoglobin, because remember the oxyhemoglobin is only measuring the oxygen. So anything not carrying oxygen will be measured, including methemoglobin. To make sure that is carboxy or methemoglobin, there is something called CO pulse oximetry, where it can measure these carbon monoxide, not the dioxide, and you can differentiate between methemoglobin and carboxyhemoglobin or other type of hemoglobin, such as silver hemoglobin or hemoglobin. Or sometimes you have to use blood gas analysis to see. Other clinical finding is congestive heart failure. So the patient can present with heart failure and shock.
Assalamu alaikum, Dr. Yahya. Thank you for your lecture. Please, I ask, what is the percentage of this premature with PDA to get heart failure? Thank you.
What is the percentage of, sorry, I did not understand the question. What is the percentage of what, sorry?
What is the percentage of heart failure and premature with PDA? Thank you.
Very common. If you don't treat, it's very common. It can very quickly cause heart failure, and it's very common. So that's what we call it, clinically significant PDA and clinically significant PDA. Now, there is a difference between PDA of congenital heart disease, that means congenital heart disease PDA, and congenital or PDA of premature babies. Now, the PDA due to congenital heart disease is rarely causing heart failure, unless 2 months, 3 months. But PDA of premature babies can early and commonly cause heart failure. And it can happen for mostly PDA causes heart failure within day 3 or day 4, between day 3 and day 6, and it needs treatment. And so most of the PDA more than 1.6 millimeter in a premature baby, especially those below 28, can cause heart failure. Okay, and the heart failure, we pick it very early because we are monitoring the baby. So you can see increased ventilatory requirement, or you can see rating of blood gas, or you can see hypotension, or you can see feeding intolerance because of stealing of blood from the bowels, or you can see also abnormal gas, or you can see hypotension, or you can see simply white pulse pressure. All these are signs of compensated shock and heart failure. So to diagnose heart failure, it depends. You can see it clinically, but sometimes also we can diagnose heart failure by echo. So failing left side. There are many ways that we measure the right side function and left side function. So you can see, so I would say very common in duct more than 1.6, especially those more than 2. Those between 1.6 and 2, not common, but if other factors, so if you have a duct between 1.6 to 2 and you have RDS, or you have pneumothorax, or you have IVH, or you have, for example, sepsis, it can easily cause this duct. But if the duct is more than 2 millimeter, it's commonly cause, if you don't treat, it commonly cause heart failure.
Dr. Yahya, thank you. One question. So we have to think that high index of suspicion, and we think of that each new premature with PDA have a heart failure, and to prove otherwise, to think of it so that we can correct this condition as early as possible?
Well, if you are first day and you give babies ventilated and you give surfactant and babies start to improve, if the second day and you already on antibiotics, you did blood culture and blood culture negative, on second day or third day, if no improvement, it's a PDA. So it's a compensated heart failure. If no improvement, if you need more ventilation, if you have any, it's a PDA until approved otherwise. And therefore, at some point, we start to use prophylactic treatment of PDA, even without echo, but we saw the complication is increasing. With availability of bedside ultrasound, and we can do echo, now it's recommended to do echo for all the babies. But the question will arise, if the baby is not symptomatic and you have a big size PDA, what you will do? So you need a protocol. So PDA is very common. More than 50% of babies below 28 weeks would have a PDA and they need treatment. So I would say it's very common if you have no improvement or deterioration after day 2 or day 3 of life. If you are not sepsis, of course, you need to exclude sepsis. Yeah.
Thank you, Dr.
You're most welcome. So they can present in congested heart failure, and congested heart failure can be slow and can be very fast. It can present as shock.
Thank you very much, Dr. Yahya.
Thank you very much. So what is the differential diagnosis of congenital heart disease? Again, many of especially heart failure. You can have structural lesion causing severe pressure. You can have primary myocardial lesion. You can have arrhythmia that can give you heart failure. So what is the, how you approach it? You need to know, is it a pressure overload or it's a volume overload? So it's a pressure overload is either aortic stenosis or coarctation of aorta. Volume overload means you have left to right shunt on the heart. It can be through PDA, it can be aortopulmonary window, it can be truncus, it can be tetralogy, it can be, especially if you have pulmonary atresia with multiple aortopulmonary ANCA, because without it, it's usually protected and the heart failure won't develop. You can have left to right shunt also. From VSD or atrioventricular canal, or you can have single ventricle, or you have anteriovenous malformation, whether in the lung or the main. All can cause volume overload and heart failure. You can have both, such as interrupted aortic arch, or you can have myocardial dysfunction, can be primary or secondary. Secondary is due to like asphyxia or sepsis or tachycardia or even brady. So once the congestive heart failure develop, then you need to look at the differential. You need to look at the differential, whether it's heart or not. So cyanosis, heart failure, but they can present murmur. Now the hearing of murmur is very common in newborn babies, especially if you do the early assessment, because remember the PDA will functionally be closed at birth, but structurally will not be closed until about 72 hours of life. And most of the murmur are due to that. So it depends on your situation. When you hear the murmur and the murmur is can occur more than 50% of children, then you need to decide whether this patient is need echo or not, or you need another assessment if he is asymptomatic. But having a murmur in that is very common, and that does not mean that you have to do an echo. You need to assess the baby more. There are transient murmurs, such as a very small muscular ventricular VSD. Sometimes you don't see it unless you decrease the window of color Doppler to see it. You have something called peripheral branch pulmonary artery stenosis. So when the pulmonary artery leaves the heart, then it branches. Once the branches is very angled branches. And when the blood hit these branches cause sound, and that's what we call it peripheral pulmonary stenosis. This is common, not rare. And we need to know, and you can see that if you drop the Doppler on the branching of pulmonary artery, you can see the disturbance. Now, the pathological murmur is different. The characteristic is different. And with the age, it will not disappear. So the murmur can be systolic, ejection murmur, can be diastolic, and it depends on the lesions. So the systolic most is happen when during contraction of the ventricles, and it means either stenosed pulmonary or aortic, or regurg mitral or tricuspid. That causes the murmur. The murmur of the left to right shunt, like VSD or PDA, usually, most of the time, most likely you'll not hear it in the first 3 days of life. So if you hear the murmur in the first 3 days of life, and it's remember when we talk about murmur through PDA, we're talking about pathological PDA, not a closing PDA. But a closing PDA getting constricted might cause a sound in the first 3 days of life. But if it's pathological PDA, it will not appear until later because it's a big size, and there is need to be change between the ventricles pressure to be heard. Now, when you hear the murmur, look at other things and look to the characteristics. If everything is fine, you just need to check the vital signs and check it again. It doesn't mean that you need to rush and ask the cardiologist to do an echo. So the other presentation, so we've said cyanosis, heart failure, murmur. The other things is fetal echo. This is very common. They do obstetric ultrasound, and if they see the heart is okay, they call the cardiologist to do the echo. And this is, and I can tell you, when I did my fellowship, we rarely ever see any congenital heart disease after delivery. Most of them, still we can see, but most of the time we see them as a fetal echo. So I'm going to pause this. So indication of fetal echo is when the obstetrician sees anything abnormal on the ultrasound, or when there is fetal chromosomal abnormality, or when there is extra anomaly, or when there is arrhythmia, brady, dysarrhythmia, or tachy, or when there is hydrops fetalis, to look what is the cause. Other indication, if the patient on teratogenic medications, or if the mother has related, a disease that causes congenital heart disease, such as autoimmune diseases or diabetes or phenylketonuria and so on. Alcoholism or maternal medications, these are indications to do fetal echo. So I am done with this session, and I hope if no more questions, I can move to the next session.
So far, we have no questions for the time being. We can move to the next session, please.
Okay.
Thank you. Doctor, you need to have a cup of water or something?
Yeah, we can take 2 minutes until we start.
Please. Yeah. Dr. Yahya, ready to start?
So in this session, I will talk about how to assess and when to suspect. Now, the most important in congenital heart disease is to pick up the emergency. So, and when we say emergency, is to avoid the shock or the congenital heart disease that can cause shock, and we pick it up earlier and start the treatment to prevent shock. And most of these presentation is low cardiac shock. So these can cause obstruction and can cause low cardiac shock, or sometimes you have a shunt and so when we evaluate congenital heart disease, and when we say time sensitive, is we are looking to the diseases that can cause shock. So how we do that? We start by physical examination as well. Of course, in addition to the history, family history, mother history, medication history, diseases of the mother, delivery, and so on, you can sometimes suspect congenital heart disease. So of course, you start by inspection, you look for cyanosis. Sometimes you see mottling. Now, when you see mottling of the skin, it can be a grave sign, but it can be just vasomotor instability. So you need, when you see mottling, you need to make sure that it's not a cardiac disease, but most of the time it's just innocent vasomotor instability. When we look to the cyanosis, remember the hemoglobin level, because hemoglobin, the higher the hemoglobin, the closer the cyanosis to the desaturation. So if hemoglobin 22, you might get cyanosis when you are 80% saturation. When your hemoglobin is 12, you will not get saturation until you're 60% saturation. So remember, the cyanosis depend on the, when you look at the cyanosis, remember the hemoglobin level. When you look also, you can see respiratory depression. And when you look at the respiratory difficulties, remember that if it's a respiratory disease, the relation between the respiratory rate and the heart rate is close. While if it's a cardiac disease, the relation between the respiratory rate and heart rate will be wide. So you will see a big tachycardia, but a little bit of tachypnea. When it's a respiratory, you'll see a more tachypnea and not that severe tachycardia. So the closer the respiratory rate to the heart rate, the more indication that's a respiratory problem. The wider the difference between respiratory rate and heart rate, the more it looks like cardiac. Palpation. So you can palpate distal extremities, you can check the temperature, you can see the pulses, you can do the delay capillary refill time, and you can check the pulses. The pulses, you might check the regularity, the volume, and also you can check the precordium, and the precordium, you can have a guess, is it volume overload? So it would be wide precordium. And when you say precordium, is the part of the heart touching the chest wall. Also, you can see the apex is moving or not, deviating or not, and is the precordium big size, hypervolemia, or it's a small size, more like a high pressure dynamic heart. You can look at the thrill, of course, check the thrills, although I'm not a good believer of these, but you know, most important is on palpation. I can see, is it hyperdynamic precordium or a thrust precordium due to pressure or obstructive lesion. You can listen, you can see the heart rate, you can see the murmur, systolic, diastolic. I don't think you need to know more than systolic and diastolic. I don't believe in very detailed description of the murmur. The reason for that, it's misleading, and second, leaves lots of study, and because of availability of echo, I don't think we will need to that details. You need to make sure this is an innocent murmur or pathological murmur, and how to know that. No other signs, monitor it over time, make sure it's not an emergency, and the characteristic of the murmur, also the location of the murmur. I'm going to pass all this. This is a list of the examination of some diseases. So when you do examination, whether you're doing inspection or palpation, you look for other signs such as trisomy 13, Patou syndrome, or trisomy 18, Edwards syndrome, or Down syndrome, or Turner syndrome. All these can be diagnosed clinically or by lab, and because of the association of this syndrome with certain heart disease, then you can guess what is the, and most of these defect, our most common defect is the VSD. Now, once you did, you can do screening, and the most important screening is for extremities, blood pressure, and saturation. Now, the blood pressure itself will not give you, but the differential blood pressure might help you to delineate if there is lesion. And if the blood pressure in 4 limbs, it gives you indication because it's not only more than one reading, and it's compared the limbs. Of course, when you measure, you need to remember that this is an oscillatory method, not the Korsakoff sound. And also you need to remember the size of the cuff, okay? How much is including and what's the width of the cuff, and because it can affect the reading. Now, difference between upper and lower by 10 to 15 millimeter mercury can indicate something, but does not mean there is a something, but need further exploration. Pulse oximetry in 4 limbs, it also can help. Preductal and postductal difference can help you with the congenital heart disease, and also it can help you with pulmonary hypertension. But please remember, is it within 24 hours or after 24 hours due to presence and absence of PDA? Now, if it's a term baby, a value of 95 is a good number to screen for echo. But if it's a premature baby, then the story is different. Or if a baby with some respiratory disease, then that's a different. Or if it's a baby born in a little bit hypoxic environment, such as high altitude, you need to figure out other cutoff. But the agreed level is anything 94 and below should be screened in a term baby, of course. X-ray might help, although not very helpful, but it can tell you the big size of the heart. Sometimes there is certain pathological feature that can tell you that there is a specific problem, such as dextrocardia or cardiomegaly or right side hypertrophy or left side hypertrophy or figure of 8 or egg on shell and so on. Sometimes it can be suggestive. Most of the time is deceiving. But the most important is signs of heart failure and signs of respiratory issues. ECG can help. The ECG can tell you that if there is arrhythmia as a cause of heart failure, or there is a particular conduction problem, or there is a particular hypertrophy of any chambers that can help you. And you can also assess from ECG if your shock is volume replaceable or not by the seeing variation in if you have a long strip by variation of the R wave. So ECG is helpful in congenital heart disease. And this is normal values of the ECG finding, although I don't like it. But heart rate in the first day of life, anything above 120 need to be, between 120 and 160 is normal. Anything above 160 should be considered. So I'm not going to go through these details. QRS measurement, you can review, you can fix this and look at these numbers. I don't look at this number alone. I usually look at the whole picture. But you need to have some idea about these normal values, especially if you have an exam. You need to know these values, the mean numbers. Look at the ECG. You can mute yourself, please. When you have an ECG, you need to look at all these numbers, not only one particular. But you can freeze this because these will be recorded. You can freeze this and look at these numbers. Again, ECG finding, you can check the rate, you can check the PR and QRS length. You can use the QT interval correct, and you can look to the QRS complex, the shape, and also you can look to the transition from right side to left side. You can also measure the axis and so on. All this can help you to, to assess the congenital heart disease, give you an indication of what is the problem. This is not evacuation, this is evaluation, sorry. So again, when you interpret the ECG, look at the rate and the rhythm, PR, QRS, and T wave, the conduction inside the heart, chamber involvement, if there is any pericardial or ischemic or infarction, or there is electrolyte imbalance, and always compare the ECG with the clinical picture. When there is abnormal, please look to the technical issues such as incorrect placement or there is no attachment to the skin. when you investigate, again, you need a blood gas to tell you how much your PO2 and PCO2. We used to do hyperoxia test. So what we do is we give oxygen to the patient for a certain period of time, 100%, and then we either check the saturation or check the, or you do blood gas. If the PO2 more than 250, it's mostly not a cardiac disease. If it's below 50 on 100% oxygen, mostly it's cardiac disease. If it's between 150 and 50, then it can be both. But remember that the lower, the more with cardiac, the higher the. So what you do is you give 100% oxygen, you wait 15 minutes, and then you do blood gas, or sometimes you can use the saturation monitor. I'm going to pass all of this. I've talked about the hyperoxia test. This is a description of hyperoxia test. It's a fail or non-fail. And of course, you have the congenital heart screening by using pulse oximetry. Now, it's vital to remember when you have a cardiac disease is not to transport, or in general, when you need to transport, you never transport unstable patients. So first stabilize and then transport. So that's very important to remember. You need a vascular access. You need to make sure that you have prostatin. You need to make sure that you are monitoring the saturation and blood pressure. It would be great if you have arterial access to measure the lactate and monitor it and so on before moving a baby. If you have a sign of shock, stabilize before you move. And then assess, make sure that you have access to the medication, a good answer. And most of the time, if the baby needs resuscitation, I would recommend to intubate and transport to secure the airway before you move, instead of having a baby deteriorate on the way and you need to stop or go back, or having a complication of the baby. So if you need a volume resuscitation, or you need inotropes, or you have to correct metabolic acidosis, and you need to transport the cardiac patient, it's better to intubate, sedate, do blood gas, do a chest X-ray. Everything is fine before you move. Make sure that you have a vascular access. Make sure that you have medications for resuscitations and for supporting inotropes and vasopressors, and you have a prostatin. It's vital. You have the prostaglandin available, and as I said, I would like to give a high dose when it's a completely obstructed PDA. And remember, we're talking of PDA, not of prematurity. It's a PDA of congenital heart disease. So I would start with high dose and go down. When it's already open and I need to maintain it, I go with low dose, and then I go up if I need. The dose is somewhere between 0.1 to 0.01 to 0.1. Sometimes people go higher, microgram, or some people, they use nanogram. So it's 10 to 100 nanogram per kg per hour. And you can increase up and down by 10%. I would start with higher dose like 100 nanometers, and go down if it's a closed PDA. So I can open it and then close it until I reach the desired level. Or I go by low if it's open and go up until I keep the desired level. Side effect.
Can I ask you, please?
Yes, please. Hello. Go ahead.
Per kg or one dose, 100 microgram?
No, it's an infusion.
Yeah, yes, I infuse by per kg or only no?
Per kg per hour.
Thank you.
Yeah, it's per kg per hour. It's between 10 to 100. Some people use more than that, up to 200 nanometer, or some people will use the micrometer, 0.01 to 0.1 micrometer per kg per hour. But you can check the dose. If my dose is probably wrong, it's not wrong, but if landed, then always it's a good idea to check the dose before you start any medications. if you fail the dose, then you need a cardiac opinion. Of course, cardiology opinion always good to before you start. But if you don't have one, then you can. There is always reaction to. It can cause hypotension, can cause arrhythmia, can cause change in temperature. So you need to make sure this it can interfere with saturation, and it can worsen the situation, because if you do not have a structural screening, then it might worsen the situation for certain lesions. That is not. It can cause more shunt, for example, that's not needed. Sometimes have a side effect if there is no structural screening. So there should be non-neonate knowledge unit without prostaglandin. Sometimes you need inotropes, and remember to know what inotropes you use. If you want to use dopamine, then the inotropic effect and the chronotropic effect until 10 mic per kg per minute. If you need more than 10, then please make sure that, because the side effect will be high. So ask yourself, should I need that or not? Should I do hemodynamics or not? Or should I use, instead of the vasopressor effect of dopamine, should I use another vasopressor, such as vasopressin or norepinephrine? The training should be, if you need more than 10, then please do hemodynamic assessment. And remember, hemodynamic assessment doesn't mean echo, but you can do many things. As I say, blood pressure, monitoring systole and diastole and the relations, and the lactate and the heart rate, and also smart monitoring the heart rate in the last 24 hours or last 6 hours. Do the histogram, tachogram, point care, and look at the blood pressure and the heart rate and other readings, and assess are you seriously needing it or not. You can use the pulse oximetry. You can use the NIRS, of course, to decide. You can use dobutamine, and it's predominantly have beta effect, and it's mainly inotropic and chronotropic, very low or non-vasopressor effect. Remember, when you need them, make sure that there should be a fluid for them to work. So if there is no fluid, so you need always to prime the circulation when you decide to give inotropes. And usually I prime it with 10 ml per kg over like 1 hour or 2 hours of normal side. So a combination of low dose of dopamine and low dose of dobutamine is a very good way. And if you need a higher dose, please consider other items. Never transport. So if you can mute yourself, please. So never transport baby without stabilization. There should be no stabilization if the baby is in this. Can you please? Rula, mute them. Dr. Rula, can you mute them?
Done, Doctor. Dr. Yahya, done.
Thank you. So never transport a cardiac baby without stabilization. Always make sure that the airway is secure. Always sedate. Always vascular access. If you have an arterial access, that will be great. Make sure that the inotropes with you. Make sure that you have prostam, and make sure that your cardiologists are aware. Make sure the other units are aware. And the principle: no transport without stabilization. So I'm going to pause. How to confirm the diagnosis? You need an echo, a structural screening to make sure that the structure of the heart. And sometimes one echo is not enough, and sometimes one person is not enough. Sometimes you need meeting between cardiology and surgeon to make it. Sometimes it's very difficult to find. Sometimes the time will tell you. Sometimes the dynamics change, the element change, until the cardiology can figure out what exactly the situation is. Okay. Sometimes you cannot diagnose by echo. Sometimes you need catheterization to delineate the finding and exactly what is the structural changes for them. And this is usually a decision of a cardiologist, not us. Here is an example of, and I'm gonna stop because I don't want to go in details of these lesions. So this is an example of a report from cardiac catheterization. We can tell you the finding, the saturation and the pressure of each chamber of the heart and each major blood vessels. And this is a list of indication of catheterization. Some of them are therapeutic, other are diagnostic, such as doing septicectomy when there is parallel circulation and there is no mixing, or when there is abnormal blood vessels that you need to open up. Or you can also, when you have a coarctation and you can, if it's suitable, the finding that you can dilate it a little bit. And sometimes you can have a diagnostic, sometimes you can use it to have a biopsy. And sometimes there is none of this, but the structure is not clear, such as coronary artery abnormalities, and you need an echo and you need a color to sometimes we use it for just hemodynamic assessment in very intensive care, especially during and after cardiac surgery. Sometimes we need interventional catheterization, as we said, a therapeutic event, and this is need a special center, of course. Of course, the baby should be ready, and the risk of baby being deteriorated should be weighed against the benefit of the catheterization. So that's mean the gestation, the size, the other complications, the ability to move, the availability of ventilation.
دكتور هي ولو الصوت والله مو واضح ممكن شوي يعلى الله يخليك بارك الله فيك.
Is that do you hear me very well?
Yes.
Yeah. So what I'm trying to say is a preparation of catheterization is very vital. And the benefit of catheterization should be weighed against the need for catheterization. And the decision depends on many factors, such as the gestation, the age of the baby, the size of the baby, and the possible complications. The general situation of the baby, the other system, the amount of support, the availability of transport machines, the availability of staff in the resource to resuscitate and stabilize. It's vital to make sure that the airway are secured. It's vital to give good analgesia and good sedation. And if these interfere with the ventilatory respiratory drive, then you might need to intubate. And you need to make sure the timing, and the timing should not be during shift changes, and cooperation and harmony between nurses and physicians and transport and cardiac center. All these need to be discussed. It's very good if you can have neonatologists observe the baby during catheterization all over the time, if it's available. You need the saturation, the hemoglobin are within the certain limit. You need to make sure that you have an access, and if it's vital, sometimes to have a central vascular access, and it will be great if you have an arterial access.
Dr. Yahya, it will be 2 p.m. within 2 minutes.
Okay, I'm almost done.
Yeah.
These are examples of, I'm going to pass all this. So these are specific lesions. So there is duct-dependent lesions, such as aortic stenosis. And these are the finding on catheterization. And this is a coarctation of aorta and the finding on that. This is interruptic aortic arch and the finding of catheterization. And this is hypoplastic left heart. Okay, with closing duct, with a patent duct and with a closed duct. So you can see duct make lots of changes. This is pulmonary stenosis and catheterization finding. This is pulmonary atresia with intact ventricular septum. This is tricuspid atresia, you can see. This is TOF, and you can see the overlapping and VSD and pulmonary stenosis. Ewigstein anomaly and sagging of or dragging of the tricuspid valves down to the ventricle, making the right ventricle, right atria big and right ventricle small. Transposition or switch. Remember that the pulmonary is anterior and to the right, while the aorta is posterior and to the left. And on echo, you will never see the pulmonary and aorta on the same direction. Always they are crossing each other. So if you see them on the same direction, this is probably TGA. Truncus arteriosus, when you have one major vessels. Total anomalous pulmonary return, and you can see that these veins are joined to a confluent, and the confluent went down, and it's infracardiac and it's obstructive. You can also have single ventricle. You know, the PDA, we're talking about congenital PN, complete arteriovenous canal, ventricular septal defect. There are very types. There is muscular, there is membranous. And now the cardiac surgery, there are different type of procedures. I'm gonna pass, I don't want to talk about it, but you can read it if you want. If you're a fellow, you need to have an idea about it. What is the early, what's the late, and what's the surgical correction. So take home message, incidence of congenital heart disease is somewhere 0.6 to 0.8% of all life birth. It can be higher when you consider the minor and very minimal type of congenital heart disease. The one that present in neonatal period is the most serious ones. Prompt recognition and treatment is critical for congenital heart disease. Never transport without stay.
You know this Yahya?
These are the you know, suggestive reading and references if you want to read about. And I would love you to read this about my friend Patrick McNamara. He's right now in Philadelphia. He was in Toronto. It's a very nice article. I have a copy of it. Somebody want to watch it, but it's very nice, very extensive review of congenital heart disease. And I am done.
Okay, thank you very much, Dr. Yahya. We have a question from Dr. Hold on. From Dr. Muhammad. What is the best inotropic support to start with in case of septic shock in a preterm? And the other part of the question is, and what is the best inotropic support with a duct-dependent systemic circulation? In those with duct-dependent systemic circulation. Doctor, you are mute.
Do you hear me?
Now, yes. Before, no.
So to decide the inotrope in premature babies, you need to decide to know the reason for low blood pressure or compensated shock. So are we losing the vascular tone? Mean the diastole will drop. Are we losing the cardiac? Mean the systole will drop. And because the systole is a propagation of diastole, the diastole will drop. So if you have both dropping, then you probably have a cardiac. Now, if both are dropping, but the distance between two of them are increasing, then probably you have a shunting. If both are dropping and the distance between them are the same, then probably it's a cardiac. If both are dropping, but they're coming closer and closer, you probably have you need to give, you have some obstruction somewhere. So it really depends on the problem. So first you need to prime. But remember, when you prime premature with a normal saline, you need to be slow and small. And you need to give time. Second, there is no normal blood pressure in a premature baby. So you look at the lactate, at the capillary refill, at the urine output, and the blood pressure, and the heart rate. And if you have saturation, you have NIRS. And then you decide, is it only vascular tone? Then you need a vasopressor. Now, the best vasopressor is vasopressin or norepinephrine. Now, we know that vasopressin will cause low sodium. So if the sodium is great, then I would start with vasopressin. If the sodium is not that, I would start with norepinephrine. Now, if the heart is the problem, then I would start with dopamine after priming, of course. And if I need more 10, then probably I need another vasopressor effect. If I need another vasopressor effect, then I would decide, well, should I increase and get the side effect of dopamine, or I start a vasopressor? Now, if I think the contractility is the problem, then I would add dobutamine. And dobutamine, I can go up if I want. Now, if I have pulmonary hypertension, I would suggest milrinone. But if there is a milrinone, then I need to prime the circulation very well. And you know, the milrinone causes diastolic effect, so it can cause some loss of vascular tone. So you need to consider, when you start milrinone, you need to consider the vasopressors. But remember always that if something is not working, do not keep escalating. Check again. Assess hemodynamics. You need to know, is your hypotension is volume replaceable or non-volume replaceable? If it's a volume replaceable, you need to replace the volume. And how I know is from collapsibility of inferior vena cava or variation of the Doppler of the aorta. Lung assessment is important when you decide to give fluid. So increasing B lines and dropping A lines, you are probably flooding the lung. Now, if you have a shunt, you need to make equilibrium between the right side pressure and left side pressure. If you have a metabolic acidosis, there is no point of. Now, if the blood pressure is not responding to your medication, then think of down regulations of the receptors. So you need to consider the steroid. Now, when you consider the steroid, always do a steroid level. If the steroid is normal, remember that the baby in stress, and the steroid should be double or triple the level. So it doesn't mean the normal level is steroid normal, then you don't need to start steroid. I don't know if I answer your question. Any more questions?
Yes. Question. What do you think about a baby who's in shock and he is on 3 inotropes?
He's in shock and he's on 3 or 3, number 3?
3. 1, 2, 3. 3 inotropic support.
It depends. It depends. Is only you have one pathology or multiple pathology? So, for example, in sepsis, you can have loss of vascular tone, and you can have cardiac depression. And at the same time, because of acidosis, you can have pulmonary hypertension. So if these inotropes are tackling these factors, yes, why not? But just giving it blindly doesn't mean anything. So if you have, for example, pulmonary hypertension, but the contractility is great, there is no point of giving multiple. You need to treat the pulmonary hypertension. But if you give medication and the medication causing peripheral, then you need a vasopressor. You just need, to have a holistic view, and you need to assess every 2 hours. Even after 2 hours, you're not responding, then you need to rethink of the cause and the reason and so on. So yes, okay. You can give a 3 if there is multiple pathophysiology of the shock or of the hypotension. Yeah, go ahead.
A question by Dr. Muhammad. Thank you, Dr. Yahya. The question by Dr. Muhammad Sayed. No lower limit for the BP?
No lower limit.
Is it all by trends?
It's all by a trend, no lower limit. Because you can have 0 and it's the wrong measurement. So don't treat numbers. Look at the trend, look at the other factors. You have your blood pressure 0 and your saturation is 95, something wrong. Okay? So just look at the trend, look at the difference between systole and diastole, and look at other factors, lactate, urine output, capillary fill, saturation, NIRS if you have, blood gas, hemoglobin level, consciousness, and so on.
Okay. Thank you. What is your review on the use of sodium bicarb to correct acidosis at time of shock, treatment of shock?
0 evidence. It's harming. It's have 0 use. It can make you feel happy, but it has no correction. It can correct the circulation, but it will never correct the tissue. Not in the brain, not in the heart, not in the kidney. So you feel satisfied, but you're really harming the baby. If people work with me, they know why, because of the double effect of sodium bicarb. I use sodium acetate when I correct over a long period of time. And when I correct the acidosis, I need to be correct very slow and a longer period of time. And also always I look at the lack time when I correct the acidosis. So if the acidosis is due to an oxy or deoxygenated metabolism, the lactate and the pyruvate will be high. So if I have high lactate and high pyruvate, I'm actually harming the baby by giving sodium bicarb, because it should be low for them to be cleared. So, and baby and the kidney and lung need time. So if I have acidosis, I need to give good ventilation to help compensating, and I need a good kidney function to help compensation. So giving sodium bicarb, you will feel comfortable, but have a zero help and have a serious side effect on the baby.
Okay.
Yeah.
Dr. Muna Tulba has a question. In case of...
No, the sodium bicarb is indicated when you have loss. So if you are losing the sodium bicarb, so let's say you do a urine analysis and you're losing, or you're losing in the stool, then yes, you can replace it. And when you replace it, you have to replace it over a long period of time. But using sodium bicarb in resuscitation is zero benefit with lots of harm. They have, and the evidence is very clear, and it's removed from NRP and removed from all other crash cards for resuscitation. Yes, go ahead.
Okay, sorry. Question by Dr. Muna. In cardiogenic shock, who is not responding to dopamine, is it advisable to add norepinephrine or epinephrine?
So epinephrine has, if I give you epinephrine, as if I ask you to climb a mountain, because it affects the heart and affects the circulation. So usually epinephrine, we need to be used very careful, and we should have arterial blood pressure, and you have central venous pressure, and we should have always cardiac assessment to use epinephrine, because it's very difficult. If you have a cardiogenic shock, so I don't know why you don't use dobutamine. Why? If you need a vasopressor effect, it really depends. If you both systole and diastole are low and they are very close, you don't have shunt, so it's a cardiac, then you need dobutamine. So I don't know why epinephrine. Epinephrine, when you have a combined and you are very sad, like an anaphylactic shock, or your heart is not pumping and you need to make the heart pumping, you need a chronotropic and inotropic effect. So epinephrine usually used for temporary resuscitation measures. And if you want to use it as an infusion for certain reason, then you need an arterial central invasive blood pressure monitor, and you need the venous blood pressure monitor. And because of its effect on the heart and minor change and more loss of, then you can use a combination of inotropic chronotropic and a vasopressor agent at the same time.
Okay.
Yeah.
Fine. A question by Dr. Anoud. If the metabolic acidosis is caused by the shock, so how could you treat it?
Well, first you need to correct the volume, and you need to remove the factors. Is it cardiac shock? Then you need to support the heart. Is it bleeding? You need to change the volume. Is it because respiratory? You need to check. Is it metabolic? You need to correct hypoglycemia. You need to correct the temperature. You need to correct the electrolyte. If it's because of renal is not functioning, you can give volume and Lasix to correct it. Okay. If it's you're losing the bicarb, then that's another issue. And remember, when you have metabolic issues, you have A going to B through an enzyme. So when the enzyme is not working, the A will be high, the B will be low. And then will be a C, which is another byproduct. It's like a river. When you close it, before the closure will be high water, after will be low water, and then the river will find a way to go. So when you have a metabolic problem, you need to correct the deficient, remove the accumulant, and also remove the byproduct. If you're losing the bicarb, you need to replace it. If you're not losing it, there's no benefit, because the bicarb is already there. You don't need to replace it. So again, it depends on the cause of the metabolic acidosis. Is it perfusion problem? Is it cardiac? Is it losing vascular tone? Is it because of accumulation of metabolite? And if you need to correct and replace, it's better to use sodium acetate. And the reason for using acetate, because it's a slow correction, not like sodium bicarb. Because when you correct the blood, your tissue will not be replaced. It needs time to replace the tissue, even if you correct the blood. So you will have normal or serum alkalosis, but you still have the tissue metabolic acidosis. You're not correcting anything. You're just hurting the baby. But if you need to correct and replace, because the baby cannot make, you can give acetate, because acetate goes very slow correction. So again, sodium bicarb is harming. It just makes you feel happy. But the tissue are still metabolic, because the tissue need at least, remember there is something called lactate. So it's 20% of what the recovery, 20% of the previous reading. So even if you correct it, there's no point, because it will never correct. The tissue is still there, because the tissue and cell need to work. The cell are dysregulated, not functioning. So you need to help the cell to function. Okay? Giving sodium bicarb will not help, and it will worsen the situation.
Okay, thank you. One more question from Dr. Muhammad Sayed. For those with a PPHN and hypotension, do you prefer dobutamine or other inotrope to start with? This is the first part. The second part is
not indicating if dobutamine is not indicated here, because you have hypotension. I don't know if the hypotension due to the heart, systole and diastolic, or just diastole, or it's due to shunt. So if you have pulmonary hypertension and hypotension, what is the cause? If it's caused peripheral, then you need vasopressor. If the heart is okay, you don't need dobutamine. And you need a pulmonary vasculature relaxating agent. You can use milrinone, and then milrinone will cause loss of vascular tone. Then you need a vasopressor, or you can use inhaled nitric oxide. So you don't need, you need ventilation, proper ventilation. You need sedation, very well sedation, and you need a quiet environment. And you need to balance the shunt between the right and left. So you don't need dobutamine. Dobutamine is not indicated in pulmonary hypertension.
Okay, another question by the same doctor. What is the best inotrope to be used in case of hypoplastic left heart syndrome with shock?
Hypoplastic left heart, it depends on the situation. If it's a cardiac, the heart is not functioning and you're depending on the heart, then dobutamine is the great choice. And prostatin to keep it open. If associated with vascular tone less, you need a vasopressor. Dopamine here is not indicated, for example, if you're talking about dopamine. Yeah, go ahead.
Okay, doctor, can you comment on the invasive blood pressure monitoring in case of the preterms or babies who are with shock?
It's very vital, because remember as we said, the cuff use oscillometers, and the accuracy of invasive blood pressure is way better if you see a good wave, because it used a transducer, a pressure transducer. So it's used decoding of the pressure to measure them. So the accuracy is way high. The accuracy is better for the systole and less than diastole, while the oscillometer, the accuracy is low for systole and diastole. You should never use the mean. So if you have an arterial blood pressure, arterial or umbilical arterial line, you get benefit two things. You monitor the blood pressure and you know you are in. And also it tells you exactly you're in the artery, not vein, because you see the wave. So if you don't have one, you can do radial or posterior tibial. I don't think it's a good idea to start inotropes without having an arterial blood pressure monitoring, unless you tried and you failed, then you don't have option. But measuring the blood pressure by cuff, it should be by automatic. So you measure it like every 5 minutes or every 10 minutes, and then over 2 hours, you will have a trend, and the trend will help you. Because even if it's wrong, the trend is great. And the trend, you can see the difference between systole and diastole, and also their level. And also you can compress it. And when you compress it, you get a shape, and that shape will help. Also, you can do histogram in last. So where is mainly your blood pressure? Are you following normal distribution curve of histogram, or you're skewed to the left or skewed to the right? So histogram can help you. The tachogram, it's help you the variations. So the bigger the tachogram is, the more variations. And remember, we are human beings, we are variables. Once become stationary, then this is not normal. So if the blood pressure going up and down, that's normal. If you lose that variability, then there's a problem. So tachogram can help you on that. Point care, it's help you to see the the number of each reading. So how many readings you get, like 30 over 30 systolic per 24 hours or per 8 hours? How many readings? So it helps me to give you the median, if you know what's median. It's more frequent. So you can do smart monitoring on your blood pressure, but looking at the numbers means nothing. Go ahead.
Okay, doctor. Yeah. Yes. You have mentioned use of sodium acetate. Do you mean to be added to the TPN, or it is as continuous infusion?
Both. You can do both. But the most important, don't correct quickly. So if you feel that the baby is not able to make a good amount because he's premature, he won't able to get a good amount of acid, then you need to help him with acid. So I won't recommend it to give it in less than 8 hours. So I would love to give it every 12 hours if you want, or continuous infusion, or put it with the TPN. Now, sometimes the sodium level does not allow you. So sometimes you're limited. So one of the reasons you have arterial, I give sodium acetate in the artery. And now the most important, when you have an artery, the rate should not be below 0.8 ml per hour. But again, this depends on the volume of, how much you're giving, what is the TFI, total fluid that day.
Yes.
So I use sodium acetate in the artery, give you a window to give some acid to the baby. Yeah, go ahead.
For the time being, I have no more questions on the screen, but we have the questions poll. What is the plan with the questions poll?
Oh, okay. Oh, let's look at the poll. So who did the question? Let's go to the poll. Who did the question?
Dr. Yes, thank you. Is there a possibility of an urgent surgical procedure for this PDA or not? Thank you.
Urgent for what, sorry?
Is there an indication for an urgent surgery for PDA, for example, a stent or something?
Surgical closure.
Or not?
PDA, yeah, sometimes we do it urgently. We mean urgent, relative urgency. We do it like within 24, 48 hours, not like immediate.
Doctor, he's asking about surgical closure.
Closure of what?
Surgical closure of PDA.
Yeah, so sometimes we do it as an emergency if we cannot ventilate the baby or need high frequency and the baby is deteriorating. So when we say emergency, it's a relative emergency. We're talking about 48 to 72 hours. It's not like immediate emergency. There is no emergency to do the PDA closure immediately. Again, you need to consider the gestation, the postnatal age, the weight, and the skills of your staff that you have. But sometimes, yeah, we use it to close it within like 72, 48 hours. But most of the time, 95% is not an emergency.
Back to the question pool.
Yeah. So this is Yaman. Yaman, you are here? Yaman. Yaman. Anyhow, I will ask Yaman to send it to everybody, the question pool, because these are not my questions, the Yaman question. Yaman. Yaman is here? Is Anud here?
You. Yes, Anud is here. She's here.
Okay, well, let's go to another questions.
الصوت راح.
صوتي راح؟
أنا دكتور.
أيوة، خلينا نشوف الأسئلة تبعتك نطلعها. Okay, let's postpone it now because it's taking a long time. We'll send it later on. We'll do another session about questions. Let's postpone it. It takes a long time. We'll do the question sometime later because I think we're passing the time. Any more questions?
هاي دكتور يحيى، معك دكتورة آمنة.
هلا دكتورة آمنة، تفضلي.
ودي أشكرك كثير على your comment regarding the sodium bicarb. لأن my observation هنا إن الصوديوم bicarb is just like a standard of care. despite we explained to them that it's harming rather than giving any benefit. But still the people here, they like to use it. Thank you for your comment.
Thank you very much. They just make the people feel comfortable. But actually, as again, you're correcting the blood gas, you're correcting the serum, but the tissue still acidotic because it's fast correcting. And the drawback is it will cause changes in the CO2 inside the brain and will affect the cerebral blood flow. So you're harming the baby because the sodium or the bicarb is there. You're not helping it. And you'll affect the cerebral blood flow because you're changing the CO2 level. So you
and
have,
now, yeah, and now sodium acetate is available.
Acidosis. Sorry.
And now sodium acetate is available. Sodium and potassium acetate is available.
Yes.
And it, yes, so it's no reason to give bicarb, I think.
Yeah, I mean, if you know that all this discovered in 2012, I think, because the sodium bicarb was not available, so they were finding alternative. And once they found alternative, they found it's better, it's not affecting the cerebral blood flow, and that's why with time they remove it and they start to compare. And so it was all discovered, the sodium acetate by just an observation by chance. So if it's available sodium, and if you have a sodium level, you can give it also a potassium acetate. And if you have potassium level, you can give it as a sodium acetate. And you can, improve other factors, proper sedation, proper ventilation, and so on. Yeah.
Okay, a question from Dr. Ali. A patient was already on epinephrine infusion and needed CPR. Would epinephrine shots make any change?
Yes. So when you give epinephrine infusion, and again, when you give epinephrine infusion, you should have very good intensive care. So you should monitor the arterial blood pressure. You should monitor the central venous pressure. You should have a cardiac monitoring. You should have NIRS and oxygenation and so on. And mostly epinephrine infusion used for cardiac disease and post-cardiac. So when you do resuscitation, the purpose of epinephrine is different from the purpose to keep the inotropic effect and the chronotropic effect and the vasopressor effect. Here it's a conduction issues. So the heart is not functioning, so you give epinephrine to resume the heart rate. So the epinephrine in the resuscitation is a little bit high. So if you are in an epinephrine infusion and your plan, but I doubt that you are on epinephrine infusion and you should resuscitate. But if the decision to resuscitate and you do CPR, proper ventilation and chest compression, and you did 3 rounds of 30 seconds, then you probably, and you give normal saline, and probably your epinephrine is indicated. Yes, should not affect the epinephrine dose on resuscitation by epinephrine infusion. In my life, in whole my life, I use epinephrine infusion like maybe 2 or 3 times, but mostly we use it in a post-cardiac surgery.
Another question, as a backbone for infusion of milrinone, you prefer to go with nor-epi, epi, or dopamine? Backbone for milrinone in case of PPHN.
I don't give any unless there is hypotension. So I start milrinone and there is no hypotension, I don't. If the blood pressure is low and it's below systemic and I want to keep it up, I use with vasopressor. If I start milrinone and the diastolic blood pressure is low, I go vasopressor. If I start milrinone and both go down, I start dopamine. If it's a volume replaceable, I start, I will give bolus. So it really depends on the situation. Now, if there is no hypotension, but the systemic blood pressure below the pulmonary and I want to keep it up, I go with vasopressor.
Okay, in case of PPHN with hypotension, milrinone will be started as maintenance, or you will start with a loading then maintenance? Loading,
always loading. Milrinone, you need loading. But I usually start with inhaled nitric oxide. It's way better than milrinone. And if the inhaled nitric oxide did not correct, then I add milrinone. And if I decide to add milrinone, if you give good ventilation and good sedation, remember, BPH, and enemy is is agitated patient. So we need a very good sedation. I sometime, not frequent, I use muscle relaxant for 1 or 2 doses, and I use very good sedation and a good ventilation and quiet environment. If that happens, rarely nitric oxide won't help. If that inosine does not help and you start milrinone and your diastolic start to drop, then you have 2 options: norepinephrine or vasopressin. Now it depends on your sodium and urine output, and if there is a PDA. If there is a PDA, and if there's a volume overload, and if there is a low sodium, I will not select the vasopressin. I would go with norepinephrine. Now, if there is no shunt or small shunt and the sodium is okay, I would go with vasopressin. If the baby have oliguria already, I would start with norepinephrine. So it really depends on the situation, because vasopressin can decrease the urine output.
Okay, what about the fear of using sedation that might induce hypotension further in a baby who's already borderline hypotensive? Or
is the baby ventilated or not ventilated?
Ventilated, and he's on sedation. The fear of using the sedation or to increase the dose of sedative.
Cause hypotension, sedation, which sedation cause hypotension and how much? I never faced a hypotension for sedation. Remember, as a physician, when we took the oath, we need to prevent pain. So it should be pain-free. Do not hesitate of using analgesia and sedation. I can tell you, chloral hydrate in my previous unit is like a Pepsi. Everybody is on it. So sedation is vital. We need to prevent pain and sedation. Anything preventing using it from sedation is a same effect as you're finding an excuse to start antibiotics. Using CRP and it's just to make and triple antibiotics. And once the baby you upgrade and you don't give as if the antibiotics is magic. And so I never faced that I cannot use sedation because of hypotension. Sedation is vital, is a cornerstone, is a pillar of neonatology.
Okay, Dr. Yahya, thank you very much. I'm not getting any more questions now, and people are sending privately thanks for the excellent presentation and informative.
It is not a presentation, it's just like a review for fellows.
This is what I'm reading for you, Yani. This is what the people has written. Thank you
Where
very
is
much.
Yaman? Where is Yaman? Okay. Okay.
I think he has joined Muna in her screen. But
where is Muna? Muna? Muna?
Yes, Dr. Yahya.
Yaman with you?
Now he's not with me.
Oh, okay. Okay. Shukran. Thank you very much, everybody.
Thank you very much, Doctor. Thank you.
Have a good day. Bye-bye.
You too. Bye-bye.